Hello again, welcome back. We're going to be talking about Chapter 7, where we'll be looking at research, studies, study design, and other related topics. And again, study design, sample selection. We'll be looking at different types of studies. We'll compare and contrast the four most common types of sampling techniques. We'll be talking about appropriate sample size for attribute and variable studies. And let's get started. My mouse isn't behaving. There's several different types of studies that we do in healthcare. One that we see a lot of is a descriptive study. A descriptive study is done to generate a hypothesis for more formal studies. This could be a cross-sectional study, which we're going to be looking at a characteristic of, say, a population at a specific point in time. So we see a lot of these during flu season, saw a lot of these with COVID and other things. We all use these a lot with prevalence. So we want to know how many flu cases we have, how many cases of meningitis was a big thing in Pacific Northwest last year, and other different types of things. We also do applied descriptive studies. So with this, we'll do some data mining, right? And we'll mine data typically from an electronic health record system. We'll do an exploratory data analysis and come to some conclusions. These are the descriptive studies. We also do analytic studies. These are a little bit more, in my head, complex. These are more formal studies that are testing something where we already have the hypothesis. So what we do with a case control study, we have a group of study subjects, and then we have a control group without this. And we see a lot of these in pharmaceutical studies. Whoops. So we see a lot of these where, say, we have a medication, a new drug that's coming out, and it's in a phase 4 clinical trial, right? So it's getting near the end of the different stages of the clinical trial. We've done the safety, we've done animal models, all these other things we're required to do that I'm not going to dive into the weeds in right here. But now we're going to be looking at whether these patients who may have a common disease, say it's something like inflammatory bowel disease, and we're looking at a new biologics, something like a Skyrizi or what have you. So we'll have a group where the group which will be matched on certain demographics will be taking the phase 4 medication, and a group without, right? So we often talk about how we match these. We want to match these for such things as gender, age, ethnicity, as much as possible. So in other words, we want both the case group and the control group to be as similar as possible. And this is often a retrospective study. We're going to be looking back at what happened while people were taking, say, said medication and the control group was not. And, we don't use these to necessarily determine cause and effect, but we can calculate the odds ratio, right? One of the problems we see with case control studies is it's dependent on the subject's ability to recall events, right? So if your study subject that is, say, taking the med doesn't take the med for what have you, you kind of have to throw that out. That's why oftentimes they'll request larger numbers for these different types of studies. We also do cohort studies. So this involves a case and control group, but the groups are identified before the study is performed. This is a way to look forward, right? So These can take a long time to complete, and if the attribute that we're looking at is rare, it's very difficult to conduct these. We also have experimental studies. So this is allowing us to kind of get an idea of what the cause and effect is between some variables. This is what we call randomized clinical trials, or RCTs. And these are used to determine the effectiveness of new drugs and treatment. We can have single blind, so a subject doesn't know if they were assigned to the case or control group, or one that we used to do a lot of at Division of Research was a double blind. So neither the subject nor the researcher knows until the study's over whether they're assigned to a case or control group, right? And with a triple blind, the subject, the researcher, and all the analytics are blinded to the group assignment, who's into what group. So we have that as well. I've never been involved in a triple blind study, to be very candid with you. Double blinds, yes. Single blinds, yes. Never been involved in a triple blind study. So why do we select the sample? Well, we can't look, if going back to our inflammatory bowel disease example, there are over 1.4 million Americans with the disease. We can't really sample that entire population. So what we need to do is come up with a sample. And ideally, we want to use statistics to get the sample to as closely resemble the population at large. And so some terms that you'll hear in these types of studies are population or universe, right? So that's like everybody that is under study and meets the eligibility criteria. And a sample is a subset of the population. So if we're going back to our inflammatory bowel disease example, there are 1.4 million Americans, I believe, who have the condition. That would be the universe. And a sample would be a number that the researcher would select, right? The sampling frame would be a list of all the subjects in the population. And then the variable would be a variable of interest, right? So it could be the new medication, Skyrizi, or what have you. We always think of these in health service research, but we also do studies about other things that people commonly run into in health information and healthcare operations. Denial rate, coding error rate, overpayment, underpayment. And even CMS now has gotten into the act where if they conclude that a provider has over upcoded and overbilled for services, they'll mathematically extrapolate what they think they're due based on the sampling. So a lot of interest in using this type of sampling, not just for health services research and clinical trials, but for other operational issues. We want to get a statistically valid sample. And what we mean is the sample needs to be large enough to tell us information that meets the goal of the analysis. I'm a baseball fan, so I'll put this in terms of baseball, right? If somebody is hitting 500 after the first week of the season, what that means in baseball statistic terms is that they're getting roughly 5 hits for every 10 official at bats. If we only have 5 games and a hitter is coming to the plate usually 3 times a game, that's a sample size of 15. That's really not going to tell us a whole lot. Whereas a typical major league hitter is gotten well over 100 at bats, right? By halfway through the season, much more statistically valid. So Another term that you hear is the probability sample, and this is where each item has an equal chance of being selected. So the idea is we want to basically be able to reproduce another sample. So here's an example. What's the percent of lab orders that are not signed by a physician in 2012? So the universe would be all lab orders. Well, we can't take a look at every single lab order during the year 2012, right? So we're going to have to sample that, right? So here's another variable of interest. What is the amount either overpaid or underpaid due to the incorrect E&M level of service code during the month of January? So the universe would be E&M services that are billed in January, E&M services provided during January, if you will. And we got to refine the question to determine if the billed date or service date should be used. So in other words, sometimes when you're working, and this came up when I worked in Medicare, ambulatory Medicare finance, when people say we want the month of January, are you talking about the month the service was provided or the month that the service was billed for? Two different things. One's not inherently better than the other. You just need to be consistent about what you're saying. And then third bullet point, what is the coding accuracy for secondary diagnosis codes on inpatient counts during the first quarter? Again, the universe, all secondary diagnoses that are coded, right, in all inpatient accounts. And then we have to figure out whether the diagnosis codes or the chart are the unit of analysis. So are we going to talk about each hospitalization or each encounter, if you will, or are we going to make it per code? And simple sampling, right? So common one that we used to do is like a 5% sample on a given day. So that would be 1 out of every 20, right? So you could do that. And again, sometimes they'll use terms like sampling unit, could be a claim, could be a chart, could be a diagnosis code, but each of them must have the same probability of selection, right? And a simple random sample isn't going to work if the frame can't be listed or if it's important that the sample has to have certain types of subsets. So give you an example. With the coding error rate, let's say we're working at a facility that does a lot of cardiovascular care and they want to have a certain amount of that. They want to have at least 20% of those be cardiovascular cases. We can't really do random sample because why? Because the cardiovascular cases, if you will, are going to have more of a chance of being included because that's what the facility has said they need. And here's what it looks like. The members of the sampling frame are assigned to random numbers, 0 and 1. And the frame can be sorted by a random number. The first number is a simple random size of size n. The other one, which we've used commonly, is we have a sequence number. We go 1 to 20, right, for a 5% sample. Then we use a random number generator. You could do this in a R, what have you, to select the random numbers, right, from 1 to whatever the population size is. A systematic random sample is basically similar to a random sample, but it's using numbers that have certain characteristics, right? So in other words, the selection is starting at random between the first and the very last number in the sample as opposed to starting with the first one. Stratified random sampling is basically we're dividing this population into subsets. And the strata, which is another way of saying the subsets, is mutually exclusive and exhausted. So each of the members is only in one strata. And then we do a random sample from each strata. And this stratified sampling is appropriate when the quantity to be estimated may vary, right? And some of the ones that we see, CPT codes, particularly E&M, something that we're always looking at, physicians, specialty, and clinic, right? So again, if we were to do this, these are the types of strata. So if we're looking at claims, we could look at claims by a certain CPT code. We could look at them from a provider. We could look at them from a specialty like orthopedic surgery or a clinic. So here is an example. An analyst wishes to select a stratified random sample of 90. So we want the sample size to be 90 from a population of 1,000 encounters that have E&M codes. And so the distribution that we want to get, that we got, I should say, excuse me, level 1, we have 55. We have 2 that are level 2, 183, level 3, 236, level 4, 309, and level 5, 217. So that's the actual distribution in this population of 1,000 encounters. So now we have that, and you can see from this chart, we want to arrive at this. So we want to get the sample to look like the population. So this is what we've kind of done, right? So we have 55 encounters with level 1. That's roughly 6% of the population. So the effective sample size, we want to take a look at 5 of these with a level 1 level of service. And likewise, for the population of 183 with level 2, that's 18%, right? The sample size is that we're going to be looking at is 16. So basically what we're focusing on here is to get this effective sample size to look and mirror essentially this, right? It's not going to be exact because that hasn't quite worked out with 90, right? And that's all I have for you. We'll see you online. Please reach out to me if you have any questions about this material. Bye now.